Good morning, everybody. Hope everyone had a good night. Buenos dias, everybody. Hola. I hope everyone had a good night and excited for the rest of the day. We have some fantastic sessions lined up. My name is Ashwin Ashok. I am with the Clinton Health Access Initiative. I'll be moderating the session for this morning. The theme of this conference is immunization programs that leave no behind, and this session dives right into it. The topic of this session is looking straight at two of the main barriers to reaching unreached kids. So one is around gender barriers, and the second is around the challenge of mapping and reaching zero-dose populations. So we have a fantastic panel, all seated and ready to present here today. Let me do some quick introductions. Dr. Anne Lindstrand, everybody, is the head of the EPI unit at WHO in Geneva. During the pandemic, she was also the WHO lead on COVID-19 vaccine introductions and delivery support to countries. Dr. Lindstrand is a pediatrician and a specialist in public health and social medicine with an MPH from Harvard and a PhD from Karolinska Institute in Stockholm. Prior to joining WHO, she has served in a variety of roles, including as president of Médecins Sans Frontières in Sweden, national program manager for immunization and NITAG, chair at the Public Health Agency in Sweden. And she's also a lecturer at Karolinska Institute in Global Pediatrics. Dr. Anne Lindstrand, everybody. A round of applause, please. Meghna Srivastav is an epidemiologist who has worked in immunizations and global health for over 15 years. She has a master's in public health from Emory University and is presently a senior technical advisor, immunization at Jhpiego, working on zero-dose strategies, measles SIAs, and COVID-19 vaccine campaigns and integration efforts. Prior to joining Jhpiego, she was with the Global Polio Eradication Initiative at WHO for 13 years. She started her career in Geneva working in research and vaccine clinical trials, but shifted to provide more regional and country-level support in EMRO and Afro regions, including Nigeria, Pakistan, Jordan, and several countries in Africa as part of the Polio Rapid Response Team. Meghna Srivastav, everybody. Dr. Yauba Saidu is a physician by training and holds a postgraduate degree in vaccinology and drug development and a PhD in life sciences. Yauba is currently the country director in Cameroon for Clinton Health Access Initiative and the Africa editor for Global Health Press, an online journal in vaccinology. He serves as a member for multiple decision-making bodies in his country and supervises students from the Faculty of Medicine of the University of Yaoundé, the Faculty of Health Sciences at the University of Buea, and the Institute for Global Health, University of Siena. Dr. Yauba was recently knighted by the President of Cameroon for rendering outstanding services to the state of Cameroon. Elena Herrera is a Senior Research Monitoring and Evaluation Officer at GSI Research and Training Institute, with 10 years of experience in global public health, focusing on maternal and child health, reproductive health, and nutrition. Elena has extensive experience in mixed methods research, including qualitative and quantitative research design, tool development, data collection, statistical analysis, and dissemination for evidence-based decision-making. Elena has experience planning, implementing, monitoring, and evaluating public health programs in more than 15 countries across Africa, Asia, Europe, and Latin America. She currently serves on the monitoring, evaluation, and learning team for the Gavi Zero Dose Learning Hub. Elena has an MPH with a concentration in health promotion and behavioral science from the University of Texas School of Public Health and a BA in global studies in Spanish from St. Edward's University. Elena Herrera, everybody. And finally, Dr. Piyush Kanti Khan is an assistant professor at the International Institute of Health Management Research in New Delhi, India. He's a trained demographer and health economist with a focus on empirical research. Formerly a senior research officer at the International Institute for Population Sciences, Mumbai, his expertise spans applied demography, economic aspects of healthcare, maternal and child health, quantitative data analysis, model specification, and multi-level modeling. Dr. Khan boasts numerous publications in esteemed international journals, such as the Milbank Quarterly, Social Science and Medicine, Tropical Medicine, and International Health, American Journal of Preventive Medicine. He holds an MSc, MPhil, and PhD from IIPS, Mumbai, India. Dr. Piyush Kanti Khan, please. And without further ado, over to you, Dr. Lindstrand.
Thank you, and good morning, everyone. Thanks for the organizer. The party was fantastic last night. And I was very impressed by the few still dancing when I was leaving. 30 degrees humid, and you managed to be on the dance floor. I'm deeply impressed. So this morning, I have short time to discuss with you why gender matters for immunization. And just to start, just on the basics, right? We know the difference between sex and gender, where sex is actually the biological characteristics, usually assigned at birth. It has physical and physiological features. Gender, however, is really a social construct. It's about norms, it's about roles, it's about relations, and it varies from society to society and absolutely evolves with time. And it has hierarchical, and often it reflects unequal power relations. Both the SDG 5 is fully dedicated towards gender inequality. And IA 2030 has this as a really cross-cutting edge piece that is relevant to all the strategic priorities we discussed yesterday. And particularly, you could say, in coverage and equity, the issue we're discussing this morning, gender is really at the heart. And we see it as cross-cutting. We really want it to be embedded in all of the different strategic priorities. And just to be coming to the basics, it's not an issue about differences, gender differences in immunization coverage between men, women, boys, and girls. It really is about the recognizing and responding to the equity and the gender-related barriers to access uptake of vaccines. So particularly on the zero-dose children and missed communities, this is highly relevant. And it's really about coverage increase for everybody, men, women, boys, and girls. And in our unit in EPI in Geneva, WHO Geneva, we produce a lot of documents, a lot of guidance. This one I'm particularly proud of, actually. This is a guidance that is part of the IA 2030 kind of body of knowledge. It aims to improve the awareness and understanding of gender-related barriers. And it is really a how-to, you know, there are really the concepts, the principles, the tools, even the metrics that you can use to assess gender barriers in your different countries is here and promoted. It also includes additional resources that you can access on this topic of gender inequalities. It's available in English, in French, and very soon coming in Spanish and Portuguese as well. So let's get to kind of the nitty-gritty of it. The gender-related barriers, they operate in multiple layers in the individual, at the household, in the community, but also in the health system as it all. What's underpinning is the power relations, the access, the different opportunities, limitations, challenges, needs, and vulnerabilities, especially for women and girls. And it affects both the supply side and the behavioral science demand side, so the health-seeking behavior. And just let me give you a few examples which you can find also in the guidance and in UNICEF's ROSA guide on gender, which is also really, really excellent. The link is here. So on the supply side, looking at the top middle piece, communities may impose traditional gender norms which hinder women and girls' full participation in health services. On the top right-hand side, health facilities emphasize the attendance of mothers and hinders which hinders women's and girls' full participation. No, which it makes it unfavorable for fathers to be part of decision-making of vaccinating or not vaccinating their children. On the bottom left-hand side, due to sociocultural norms, in some settings, only female vaccinators can access households. If you look at then the demand side, on the middle piece here, I want to highlight top middle piece, that women in some areas will not be allowed to travel to healthcare centers alone due to sociocultural or gender norms, but also basically security issues. So what do we do about that? On the bottom left-hand side, women are considered to be the primary caregiver for children, but may not be the sole decision maker. So child health care with limited access to and control of the household resources to utilize the health services. So unequal access to everything from time, information, money, transportation. So what can be done against it, right? What can we do? How can we transform immunization services so that become more gender responsive? Well, on the piece of women having limited mobility, time, and control over the resources, of course, bringing the vaccines to where the women are. Offer extended vaccination hours so that mothers and fathers together can come, or safe transportation that could be helped. Offering appointments for many siblings at the same time, not having to go those long distances for one child at a time. The gender dynamics in decision-making, to engage fathers early on. We know that if you have both parents, mother and father, engaged, willing, wanting to, and taking part of the decisions, the coverage actually goes up. On the cultural preferences for female health workers, I think this is maybe the most known, so to say, gender intervention that people know about. Increased number of female health workers, and maybe provide a safe space for women only to get vaccinated. Also, on the negative experience for mothers, for fathers entering into health services, the importance of interpersonal skills that could be promoted much, much more, which is not only important for gender barriers, obviously. And then maybe have specific clinics for young mothers who are stigmatized in so many layers, right? I also want to say the poor working conditions and gender discrimination of health workers, also super important to look at the gender construct of managerial decision-making power in health services. So it's not only this brilliant guide that I want you all to read. There are other things as well, integrated into the guidance for national immunization strategy. You have a gender section, so really look at the gender barriers. We see that in the first NISs that have been developed, the analysis is there, the implementation of breaking gender barriers is not maybe where we want to be. The middle part is situational analysis, where you actually access and look at specific barriers and rate them. And then on the right-hand side is the behavioral and social drivers of vaccination with metrics and survey tools that you can use, inclusive of also the supply side and the gender and the demand side. So we all need to be more literate, right? And we've built out a Gender Pro course that I want my team to all go to, right? There is a short one, there is a long one. There's one which is 15 weeks, one is 4 weeks. They are about 1.5 hours to 3 hours, very well invested time to change our minds of how we assess gender and act on it. And there are upcoming courses that you can see. So our gender team, Tracy, Stephanie, and Carol, you can contact them if you're interested, and they know much, much more than I do. Just in conclusion, So women are disproportionately vulnerable for the negative impact of the gender barriers, climate change, and immunization inequities. Look at it, female health workers constitute around 70% of the health workforce, but only 25% of those in senior management decision-making power. There is usually a gender gap, and they may face discrimination, insecurity at their work health. Mothers also experience gender barriers, limited decision-making, authority, physical time, cost barriers, lower education, and gender-based violence, which firmly affects if you actually dare to disclose and come closer to health services as well. And if we look ahead, 1.2 billion population is estimated to be displaced by 2050 due to climate change and natural disaster. And women, we know, are disproportionately impacted by forced displacement. So looking ahead, all of us in immunization need to have this gender-centered lens and think about the solution, transforming our immunization services to be much, much more aware. And on a scale from kind of dumbness, gender unequal, up to gender transformative, we all want to be on the right-hand scale, either gender sensitive, being intentional about what we do, or gender transformative, of actually looking at the underlying root causes of gender inequalities and transform services accordingly. There are lots and lots of guidance from WHO, UNICEF, Gavi, but I think we all need to take a personal commitment to actually learn much, much more. Thank you.